All right. Good evening, everyone. I'd like to welcome everyone to tonight's MSIG webinar, where we're continuing the series on textbook injuries. Each speaker tonight will share their expertise on a specific sport and identify the most common injury or injuries from the sport. It's an honor to have the following AMSSM members serving on our speaker panel tonight. Dr. Charles Peterson will give a presentation on rock climbing. Dr. Andrew Pasternak will give a presentation on ultramarathons. Dr. Joshua Snodgrass will give a presentation on surfing and skateboarding. And Dr. Brian Merrigan will give a presentation on scuba. My name is Kirra Borrello. I'm the current MSIG president, and I'll be serving as the moderator for tonight's webinar. I'm currently a third-year medical student at the John A. Burns School of Medicine at the University of Hawaii. So I'm really interested in hearing the surfing portion tonight specifically. Yes, we're looking forward to tonight's webinar. After all of our speakers have shared their presentations, I'll serve as the moderator for a Q&A session with our speakers. During the webinar, please enter your questions in the chat and I'll read each question during our Q&A segment at the end. So it's my pleasure to introduce Dr. Charles Peterson, who will give his presentation on rock climbing. Dr. Chuck Peterson is a sports med physician at Arizona Sports Medicine Center, which he helped found in 2004. He is a team physician for the Arizona Diamondbacks, Arizona Cardinals, Chicago Cubs, U.S. Ski Team, and Mountain View High School. He's a former physician for the Phoenix Coyotes and served as head medical physician for the Phoenix Suns. His practice will begin care for the Phoenix Rising Soccer Club this next season. He obtained his undergraduate degree in history from BYU, attended medical school at Northwestern University, completed family medicine residency at Mayo Scottsdale, and was fellowship trained in sports medicine at the Medical College of Wisconsin. His practice emphasis includes overuse tendon injuries, degenerative arthritis care, fractures, and care of the athlete. He performs ultrasound-guided procedures, including percutaneous tenotomy, carpal tunnel and trigger finger release, hydrodissection of nerves, and hydrodilation for adhesive capsulitis. Chuck is gratefully married to Gayla, and they have 5 children and 3 grandchildren so far. He grew up in an outdoors family and got involved with climbing as a Boy Scout. His most recent adventure was a pack rafting trip down the Colorado River with the canyoneering side excursion in late October. Chuck and his family enjoy climbing, skiing, hiking, and he dabbles in triathlons. His greatest joy is his family and those little grandkids. Dr. Peterson, please begin your presentation.
Thanks, Kirra. Thank you for having each of us speak. Appreciate the invitation. I'll share the screen now. There we go. Okay, so again, this is the rock climbing segment, and I'll introduce a little bit about that and then some of my experiences and then into the most common injury with rock climbing. So one question was, how did I get into climbing? Well, this is my dad. George is almost 89, and he's still, this was him just about a week ago, hiking up to his favorite waterfall. And a couple years back, this is him ice climbing. So it's hard to not get into some of this stuff when your dad is George. And so with, let me go back one. So when you think of biomechanics of climbing, you think of a long, lean, strong man that can just hold onto rocks with his bare hands. But it's not always as it meets your eyes. This is my son, Scott. And what he was really doing was laying down on the rocks, pretending that he was a rock climber. So it's not always what meets the eyes. The actual best natural climbers are actually young women. They tend to, this is my wife here on this sport wall. And women tend to be more natural as far as using their legs for their strength and keeping their hips against the wall and just do a better job. And these are all my little nieces going up a half dome. And so that's kind of interesting with biomechanics. And so let's see. Trying to see if there's a way to move. There we go. All right, so training variables are actually more important than body type. And we're looking for, as far as body type, leanness, strength, and flexibility certainly helps. It involves activities with reaching, stretching, pulling, pushing, bridging with legs, and hanging. And again, young girls are the most natural. Outdoor climbing uses the greatest amount of energy expenditure, and a lot of that has to do with getting to and from the climb. And hand fatigue lasts for 20 minutes, and that comes into play, especially with sport climbing in gyms and bouldering, where there's just one problem to the next. And when you stack those, you can really get into a situation where you overuse those hand tendons. This is me up in Rocky Mountain National Park a couple years back, and there's Long's Peak in the background. All right, so climbing injuries in general, some of the most common things have to do with skin abrasions, especially in less experienced climbers. The feet, you cram them into shoes. They're a couple sizes too small. You can get into foot problems. So we come in and out of the shoes frequently, unless it's a big wall with multiple pitches. With upper extremities, we have a lot of tendon and ligament injuries, particularly with the hands, but you can also have elbow problems with the biceps and with the common flexors, common extensors. Shoulder, you can have long-handed biceps tears. Lower extremities, there's a specific injury for climbing that happens with the lateral collateral ligament from heel hooking and pulling your weight up with your leg up above your head. Falls, of course, can give problems, and if you're close to the ground, you can come down. And I've had athletes who tear their ACLs because they were trying to clip into the first clip, and they fall and then land and fall maybe 6 feet and then land funny and tear it, fractures, etc. Some of the most common things are overuse tendinosis. And then we also have to look into exposure and environment when you get into some of the bigger things with mountaineering, alpinism, depending upon the nature of what you're doing, sport climbing, trad climbing, traditional climbing, setting your own gear versus having clips. And then solo climbing, where insane people climb without ropes. You've probably all seen the movie. Gym climbing, there's sport climbing. There's also bouldering, where they don't use ropes but don't go as high. So depending upon what type of climbing, there's different exposures. And then there's sort of mixed media, whether you're doing ice climbing like my pop, or getting up in alpinism, going across ranges, and then canyoneering is another interesting way that you can get out and do climbing. Elements of climbing, mix it with other things, and so it becomes complex when you have multiple different sports kind of attached. There we go. So here's my son, my other son, this is Kurt. He's an excellent boulderer, and so as an example, you have all these things on the wall, but his particular route was a very difficult one where he only used these little white ones, and he was proud that he got up that problem. They'll just spend hours working on one little problem again and again and again, and so you can get into overuse tendinoses. So this is Kurt a few years back with some canyoneering. So I wanted to just show some of that mixed media. This is Christopher Creek in Arizona, and there's multiple pitches. You go down through a river with waterfalls. This is me a couple months back in the Grand Canyon, and it gets bigger. And we had several pitches that were 150 feet, where you're just going and going and going, and you're mixing elements of scrambling through. Sometimes there'll be some climbing, especially to get out of a pot or a keeper when the rope drops you down into a hole, basically. But there's a lot of rappelling and getting down. But sometimes there are elements getting to the headwaters of the canyon where you have to do some climbing to get up and out. And then it turns into other things. This is my nephew on our most recent trip. Next thing you know, he's climbing up without ropes and doing backflips into waterfalls and things like that. So climbing can turn into all sorts of fun things, and Rush lives up to his name. This it's kind of noisy, and it went away. Oops, let me get back. Well, that video didn't work. It was going to show me going down the rapids, but that's fine. And then I capsized. So then finger pulley injuries is the specific injury I wanted to focus on. And this is our son Giovanni, and he's doing that heel hook where you can get those LCL injuries. But finger pulley injuries, it's the most common climbing injury. It's often related to repetitive overuse. You'll see it with gym climbers who go over and over and over again. They might have a gym subscription and go every day. You know, our son Kurt was going every day after school. And bouldering in particular, you can get into these situations. Handholds have a lot to do with it. You'll have crimp, you'll have open and vertical grips, and then pocket grips where you're hanging onto a little something with one finger. And so different grips can have different effects on the tendons and on the pulleys. And the biggest problem we get into is with inadequate rest and also insufficient care. There's insufficient self-care by the athlete who just thinks they're indestructible, and they go ahead and just keep on going and have little injuries, have little troubles, and they just keep on climbing. And then the other trouble with climbing and injuries, and with overuse injuries in particular, is a lot of providers that they see are simply not that experienced with climbing injuries. And whenever a climber is told, well, just stop climbing or just don't do that anymore, that the ears turn off, and that's not that helpful. So a lot of climbers get into that situation. So with finger pulley anatomy, just looking at the finger, you can see here schematically where the different pulleys are on a finger. And then here there's these cruciate pulleys, but the main pulleys are A1, 2, 3, 4, 5. And some of the main pulleys we worry about are 2 and 3 as far as the specific injuries. And just to give you a little bit of background, A1 pulley is the one that you'll typically cut when somebody has trigger finger. But from hanging on rocks, you'll get, the most common would be A2 pulley injuries. And so examination skills, sometimes, you want to use your ears. You got everything in your hands. So examination skills, there'll be a pop, there'll be sharp pain, might have some swelling. They'll call it sausage fingers when the finger's all swollen up and down. You can have some bowstringing where the finger kind of looks thicker as you flex the finger. You'll be somewhat point tender to that pulley where there's an injury. And also the climbers will notice diminished ability. They can't do their holds. They can't do the same level of difficulty, and they have diminished endurance, and they'll have pain with flexion and some weakness. And then there's imaging that's quite helpful. We'll start with x-rays. That's usually useless. You'll only find something on x-ray if it's a fracture or some sort of little avulsion fracture. And on occasion, you'll find stress fractures. And so it can be helpful in those circumstances, but otherwise, and then arthritis on occasion you'll find because of the overuse to the phalanges. And then ultrasound in some studies can be up to 100% accurate. I don't think that's always that way, but ultrasound can be very helpful. And MRI is kind of the gold standard to look for these pulley injuries. As far as a treatment algorithm, this is from Schoeffel. He's Victor Schoeffel out of Germany. He's the world expert on pulley injuries, and he's a fantastic hand surgeon and climber. So if you suspect somebody has a pulley injury, and by the way, this can happen with climbing in particular, but I've also had somebody get a pulley injury from lifting a treadmill to move it in their basement gym. So you think of it in different circumstances too. But if you suspect it, of course, you get an x-ray. If there's a fracture, then you manage that. If there's not a fracture, go to ultrasound. And if there's greater, if you look for 2 millimeters of the tendon being lifted away from the cortex of the bone. If it's less than 2 millimeters, then it's a strain. It's not completely torn, and we treat that symptomatically. So they can climb as they're able with some limitations. If it's greater than 2 millimeters, then typically you'll do an MRI, and you'll look to see if there's a single rupture versus multiple ruptures of pulleys. Single ruptures, we're doing conservative. Multiple ruptures often need surgical repair. If you can't quite tell, you get the MRI also, and you move on from there. This is my brother, Paul. He's our family guru. All right, so here's with ultrasound. And again, it can be very, very accurate in the right hands. It's also very useful, of course, because you can do dynamic testing. Normally, the pulleys are thin and kind of hyperechoic bands. You don't see as well laterally with ultrasound. That's one of the limitations because of anisotropy. When there's a pulley rupture, you'll see some discontinuity of the pulley. You'll also see hematoma sometimes, and you'll see the bowstringing of the tendon, as in this picture down here. The tendon's pulled away a bit from the cortex. And again, greater than 2 millimeters is our situation where we're worried about it. If there's a strain rather than a rupture, we're looking more for pulley thickening and some hypoechoic edema. So those are things that we can look for with ultrasound. And with MRI, of course, as you can see on this image here, the central digit there is an A2 pulley. You can even see that little black band flapping in the breeze a bit, and the tendon is pulled away more than 2 millimeters, but pulled away from the bone as compared to the other digits around it. And this shows some of this pulling away as well on this digit on the side view. But again, MRI can be the most effective. The axial slices are superior because you can actually see in plane the pulleys themselves. And you can potentially do an MRI if you're able to get them to do this for you in the normal and in the stress position. That can be helpful to see the dehiscence away from the cortex. T2 is helpful as far as seeing edema and the acuity of the injury. T1 is the best without fat saturation so that you can actually see the dark band. And the biggest thing with MR is to make sure, as in all things, I suppose, make sure you know your radiologist, that they've got experience with these injuries, and be super picky. So Schoffel's grading system is excellent. If it's grade 1, it's more of a strain. Grade 2, there's a complete rupture of 4 or a partial injury of 2 or 3. Grade 3 would be a complete rupture of 2 or 3 pulley. And a grade 4, that would be multiple ruptures. And sometimes it can involve lumbricals and collaterals. So that's a more significant injury. And as far as management of these with with Schoffel's algorithm, if there's a grade 1 more pulley strain, it's conservative. You don't really do immobilization with this. You can do some functional therapy for 2 to 4 weeks. You'll tape, and I'll show you a little bit of some taping techniques in a second, but you'll tape these. And then easy sport-specific activities you'll do after about 4 weeks, doing some rehab with it. Full sport, usually by 6 weeks, and then you tape for 3 months. Usually, and Schoffel's technique is called H taping, which I'll show you, but that's some sort of taping technique is a good idea for a few months. If there's a grade 2 where there's a complete A4 pulley or a 2 or a 3 partial, again, that's conservative, and usually immobilize it for about 10 days and then do the therapy the same and taping the same as a grade 1 strain. As well as easy sport-specific activities after about 4 weeks. And this takes a little bit longer to get to full activity, but not much. So as you can see, a grade 2 is treated very similarly to a grade 1. When we get to grade 3, it's a little more significant. We have a complete rupture of 2 or 3. And for just normal activity, they might not have a problem. But for a climber, it can be a fairly significant injury. This is also typically treated more conservatively, but the functional therapy is longer, and usually they'll have some sort of thermoplastic or ring that they can wear as a pulley protection, and it takes longer, usually more like 8 weeks to get back from something like this, and full sport usually about 3 months, and then 6 months with taping protection. If you have the multiple injuries in the grade 4, then it's typically surgical, and they're immobilized post-operatively. And then beyond that, a similar treatment regarding grade 3, but in some ways, because it's been repaired, it can be a little bit quicker getting back to some of your things. But basically, it's going to be 4 months for easy sport, 6 months for full sport, and then greater than 12 months, you should be protecting with taping. So this shows kind of schematically where the pulleys are, and you can see with the cartoon drawing of the climber over here, this is a A2 pulley that's being torn, and why it's being torn with this crimp grab here and just tearing up against that pulley partially, and then it can become complete. And there are different ways to tape. You can take a strip and strap it around and make an X pattern like that, or you can do the H version where you tear or cut and put the untorn portion against the volar plate, that flexor portion, and then strap around either side there, and that just tries to hold onto the A2 and the A4 pulley to give it more protection. And this is a schematic again showing it on somebody's finger rather than a diagram of how you can do that H taping, which allows, the nice thing about it is it does protect for that pulley, but it really allows for better motion than some other methods of taping. So the H taping in Dr. Schoffel and in my experience, I think is superior. So the surgical approach, this shows where you can, just some of these surgical approaches and just seeing what the ligaments look like there, but you can come from laterally or from the volar approach. And then that's the main thing. So again, climbing is one of those sports where you can start young. This is my grandson, William, with my son, Josh, who's an ortho resident in Chicago. And this is my niece over here with her pop. Start young and do your best not to get into situations you can't get out of. But again, many different types of injuries that can occur in climbing, but this is the pulley injury.
Thank you, Dr. Peterson. We really appreciate your presentation. Now it's my pleasure to introduce Dr. Andrew Pasternak, who will be presenting on ultramarathons. Dr. Andy Pasternak is a board-certified family medicine physician in Reno, Nevada. He's the owner of Silver Sage Sports and Fitness Labs and is a community professor at the University of Nevada, Reno School of Medicine, where he works with the Family Med and Sports Med programs. He is a past president of the Nevada State Medical Association. He's currently the medical director for the Western States 100 and Tahoe Rim Trail Endurance races. His 2025 goal is to start a community honk music band while playing his tuba. Okay.
All right, thank you, Kirra. Let me share my screen here. There we go. So yeah, thanks for the introduction. So I'm going to talk a little bit about medical issues at ultramarathons and what my experience has been. I think one of the things that's always kind of fun is like, how do you get to, get into ultramarathons? And I grew up in suburban Detroit. I was not much of an athlete. I went to the University of Michigan for undergrad, got married to an anesthesiologist during residency in Madison, Wisconsin, and started running in part to try to keep up with my wife. She was really an avid runner. We moved to Reno in 1998, and I started my own family medicine clinic in 2005. What kind of happened for me is I had been a road runner, and then around here in Reno, we just have a plethora of trails. And in 2010, the race director for the Tahoe Rim Endurance races was looking for a medical director, and they went to the sports medicine fellow, and he didn't really know what to do, so he approached me, and I got involved with ultra running through that. Got involved with the ultra running communities, written some papers, and then in 2019, I had the huge honor of becoming the medical director for the Western States 100, which is the oldest 100-mile trail running race in the world. So let me talk a little bit about some of the issues that we see. We'll talk about some of the severe issues. I'll dabble a little bit about rhabdo and AKI, which is something that's we're seeing a lot of recently, and then some other assorted things. So one of the biggest things that we worry about in ultra running is obviously hyponatremia. As you guys know, normal sodium levels between 135 and 45. If it's less than 135, that's considered hyponatremia. The incidence is anywhere between 0 and 51% in a lot of endurance races. And there's been 14 deaths from it. So there's been a lot of education going on amongst our athletes, talking to them about drinking to thirst. This is a photo of me at Western States, I think 2 years ago, with Tammy Hugh Butler, who's one of the biggest researchers and advocates. Tammy and I have become good friends, and these are actually her slides from her talk on hyponatremia. If you ever get a chance to listen to her, she's fantastic. So hyponatremia, we typically think of it as a water retention problem. The biggest issue that we were seeing for a long time was sort of novice runners overhydrating during a race. Recently, what we are finding is that in longer events, especially at the ultramarathon level, there probably is some sodium loss going on as well that's contributing to it. So again, there's sort of this pure water retention due to SIADH. There's also this sodium depletion. I think a lot of our runners are probably somewhere along this spectrum of both etiologies. But the one thing that definitely happens is you do have this SIADH where you have the AVP secretion, and so the runners are not urinating as normal. Some of the signs and symptoms, one's like, my weight's gone up, I'm bloating. We tend to think of that as an overhydration versus if they're like, man, I feel thirsty, that could be more of a sodium issue. Again, it can happen with any event. The longer the distance, the more we see it. They've seen it in shorter races where people are really pounding water. Again, as we get longer, we think it's probably due more to the sodium loss is probably a part of it as well. So this is the third International Exercise Hyponatremia Consensus. Treatment for it, if you have someone who comes in and it's mild, you want to try to restrict their fluids, give them very, very salty stuff. Most of your Gatorades and sports drinks don't have enough sodium in it. So we'll do things like bouillon cubes, Sometimes we've even cracked open some of our hypertonic saline and mixed it in with some Kool-Aid or something like that to try to get the sodium up there. If someone's severe, if they're having seizures, that's where we have hypertonic saline in all of our medical kits, and we'll give boluses of that and try to treat this. Compared to, where you're dealing with chronic hyponatremia and you're worried about central pontine myelinolysis, really the recommendations are to try to treat this aggressively with hypertonic saline. One thing I tell all of our runners and everybody involved is please avoid IV hydration spas. They're the bane of my existence. I've written about them. We really worry that runners, if they either go to the IV hydration spas before the event or after the event, they're not going to get the right treatment. They're not getting their sodium levels. And we've had a couple of elite runners run into some problems where they've violated WADA protocols and have gotten some discipline due to that. So we tell all of our athletes to avoid those places. Heat illness, Marty Hoffman, who is the previous research director for Western States, always said, we don't see heat illness. The runners are smart enough to slow down. And he had never seen it. We're starting to see it more, especially at Western States. Runners finishing in what we call the golden hour, which is between 29 and 30 hours of finishing. They're pushing hard to finish. Temps in Auburn, California are often, around 100 degrees. This is a runner this year who she actually finished after the cutoff. And luckily we had a data therm with us this year. We got a rectal temp on her and she was 104. We cooled her down. She did great, but it's something that you obviously see, especially in hotter climates. Rhabdo and AKI, it's obviously common. We see it, it's a spectrum of disease. We can see it with any sort of physical activity. This is me marching with my sousaphone, and I probably had some rhabdo after I did that for a couple miles. Now, the one thing I tell, we have runners who go to the ER after a race, they're not feeling good, the ER gets blood work, and they're like, oh my God, you have rhabdo. All of our runners have rhabdo. If you look at our CPK levels, again, this is some research from Marty Hoffman, we'll often see CPK levels of 10, 20, 30,000, really, really common. So what we try to tell our runners is it's not just the CK levels. What we really worry about is what are your kidneys, how are your kidneys still functioning? And this is one of the things we've unfortunately had 4 runners end up on dialysis after Western States in the last couple of years. This is a paper we published a couple of years ago. Interestingly, all these runners were hyponatremic at the time of presentation. We're trying to do some research to figure out if that hyponatremia, if they were hyponatremic, is that contributing to why they're getting rhabdo and more severe disease? Non-steroidals, Bob Weiss, who's the previous medical director of Western States, who is a nephrologist, calls non-steroidal induced AKI the most preventable, stupid condition we treat. We don't have anti-inflammatories. We tell our runners, please do not take anti-inflammatories during the race. GI issues, big problem. A lot of runners, if you work at an ultra marathon, you're going to see runners puking, vomiting, see a lot of nausea. We'll see some lower GI issues. It's the most common reason why people drop out of races. So what we try to do is just have a wide variety of foods. There's some data that maybe in their diet during a race might have a little bit less, but we're still working on some of those issues. Can't do a talk about ultramarathons without talking about blisters. They're obviously common. It's probably the #1 thing that we do at races. And here are some of our prerequisite ugly blister photos. I won't go too into blister care other than to mention if you are working with runners who get blisters, Fixing Your Feet by John Van Off and Tanya Olson is fantastic. John's kind of transitioning out of ultra marathon care. Tanya's taking over, and she's a fantastic resource in helping our runners. She comes out to Western States from Florida every year to help us out. Musculoskeletal issues. Again, we see a lot of runners with IT band syndrome, muscle cramps. This is Courtney DeWalter, the year that she actually DNF'd at Western States. This is her coming through our aid station at Peachstone. And she just had a really bad patellofemoral. Most of our runners are going to try to push on. They're going to try to limp and get through things. We also see the leans. This is a friend of mine at Western States this year, and we see this at ultra marathons. We have no idea what causes this. It's something we keep wanting to research. But you get these runners where they're conscious, they're doing everything, they're not delirious, but their core muscles just go into spasm and they get that kind of lean. A couple of, this is just a more difficult ortho case. This is a good friend of ours who was doing Western States 2 years ago, was having some pain. He thought it was his IT band. He was actually right outside of our aid station and then ran about another quarter of a mile down the trail and felt a pop. And this is his displaced femur fracture that we had to get him out of that day. Fairly uncommon. But, you know, the reason why I do this, it's a fun sport. I've gotten to meet runners from all over the world. In this photo, we have runners from Singapore, Norway, Scandinavia, multiple places. And one of the other things that I didn't mention is this is my wife actually finishing Western States this year. Like I said, she's an anesthesiologist, and she was lucky enough to do the race this year. Finished the race in the golden hour, and it was just a spectacular day. One of the things I am starting to do is I just love working with these athletes. So I'm actually starting a podcast now where I am going to be interviewing athletes with various medical issues and talking to them. And I'm really excited. And the photo there, this is Will Barkan, who's a legally blind runner who ran Western States this year with my wife. Will unfortunately finished 31 seconds after the cutoff. But it is still just inspiring stories. So that is the end of my talk.
Thank you, Dr. Pasternak. I should have mentioned this before the presentation, but I was lucky enough to volunteer at the Ironman in Hawaii the last couple of years, so that was really interesting. Thank you for sharing. So now I will introduce Dr. Joshua Snodgrass. He will be presenting on surfing and skateboarding. So Dr. Joshua Snodgrass started his journey as a mechanic in custom hot rod shops and on racing teams. After receiving his undergraduate degree in neuroscience from the University of California, Santa Cruz. He then returned to academia and medical school to complete a residency in family medicine at Phoenix Baptist Hospital, followed by a fellowship in sports medicine at Long Beach Memorial. He also completed a master's degree in cybersecurity at SNHU in his spare time. Dr. Snodgrass now provides medical coverage for many professional skateboarding, surfing, snowboarding, and mountain biking events. He has served as team physician for California State University, Long Beach, and Cypress College, in addition to being medical director consults for Medicine in Motion, Vans, and the X Games. In his spare time, he surfs, rides motorcycles, snowboards, and enjoys watching MMA and hockey. Dr. Snodgrass is also an active blogger at parentingadventures.com. So now, Dr. Snodgrass, the floor is yours.
Thank you very much. Make sure I can get this to share. All right. The action sports world is a little bit different than most of our organized sports, so I'm really excited to be giving a talk on it finally. I apologize, I'm going to have to gloss over as kind of a high level just because of the nature of two sports in a short period of time, but I'll do my best to hit most of these spots. The photo that you're looking at was our medical team from X Games Ventura 2024. And of note, you have my two current fellows right here, one of my old fellows there. That's me with a boot on. My 8-year-old in jiu-jitsu decided to tear my Lisfranc ligament in my foot. And then one of my old fellows right here, and then another old fellow, Andrew Noby, who is now faculty at the UC Irvine Sports Medicine Fellowship. But typically when we go into these events, we have a very large medical team consisting of athletic trainers, physicians, PTs. A lot of times we have chiro on staff as well. So what we're going to look at is understanding how the action sports came to be. Where did the X Games and surf skate, how did it explode in such a short period of time, and where is it heading at this point? Then we're going to take a look at some of the style versus efficiency in terms of biomechanics, look at a little bit of the epidemiology, and then we'll talk about a couple of interesting cases. This trophy on the left is one of my favorite trophies. This was from 2016, the Vans pool party. The competition took place on May the 4th, hence the Star Wars theme. But unfortunately, Vader's lightsaber broke, so the trophy was missing one little piece right there. So a brief history of time in terms of how the action sports industry kind of evolved in terms of surfing and skateboarding. And what you're seeing here is a bunch of different tail designs on various surfboards where it was based on all fluid dynamics. Everything's going to be a little bit different in terms of what type of fin placement, where, how big, how small the fin is, how many fins you have in a board, and each tail is going to depend on how that rider wants to attack the wave. Um, what most people don't realize is how old some of these sports actually are. Surfing, we can trace its heritage back into the 1700s and 1800s. It was originally documented by Captain Cook when he was out discovering the French Polynesia, Tahiti, and kind of saw a lot of this in Hawaii. But it wasn't until later, the 19th century, sorry, the 20th century, when it made its way to mainland US, which was a guy by the name of George Freeth. He was surfing over, or went over to Hawaii to vacation, and kind of saw these guys surfing and didn't really know what it was, and decided that he wanted to try it. So he ended up enjoying it and brought it back to the US. And this photo on the left was originally taken at the Huntington Beach pier dedication back in 1914. It's kind of interesting for me because I currently live in Huntington Beach. I grew up down here, and when you get into terms of like how do you get involved in these sports, you're kind of, a lot of us grew up in the industry in the middle of it, and you'll kind of see a trend of the mindset of an action sports athlete is a little bit different than your average organized sport. So let's switch gears a little bit here. Surfing originated in the 1700s or even earlier than that, we don't know. But skateboarding, we've got a lot more documentation on it, where it kind of came about because the surfers wanted to maintain that flow and sport on the land. And so in the 50s, what they were doing is they were taking the wheels and trucks off of these roller skates and screwing them into these wood planks. They originally started out as a scooter, but over time they decided they were going to rip the handlebars off and just kind of bomb some hills on it. But it wasn't until the 70s when skateboarding really started to explode. And I believe it was 1972, there was a company called Cadillac Wheels. The Cadillac, what they did is they took the steel wheel and said that they could improve on it. And it was the first time anybody had ever created this polyurethane style wheel that was a little bit more forgiving on the concrete. The reason that's such a pivotal moment in skateboarding was because the urethane compound that Cadillac used to make the wheels is what was the premise for building this little tiny bushing that went on what's called a kingpin on a truck, which is the center bolt. That bushing let the solid steel trucks that we were using, it now let them pivot, which was game changing at the time. When you look at the timeline of it, you go from 1972, urethane wheel is invented, 74, the bushing is invented, and by 1976, we're seeing the first skate park being built in Carlsbad, California, Southern California. Carlsbad's kind of a hotbed for a lot of these action sports, and the neighboring town right next to it, Encinitas, which is where I actually grew up. If you look at a lot of the pro skaters today, they often live in one of these two towns. Even the BMX industry with Bob Haro started at this exact skate park. The reason that the skate parks became a big thing is because you could actually get the feeling of riding a wave on land. And the nature of the action sports was just to kind of keep pushing that limit further and further. And it's kind of interesting because that mindset of action sports athletes, it always reminded me, if you remember, I don't remember what year it was, but it was a guy by the name of Roger Bannister. If you're into the running side, you'll probably know that he was the first person to break that 4-minute mile. And at the time, doctors even thought it was impossible, like humanly impossible to run a mile in sub 4 minutes. But the day that Roger Bannister did it, within a couple of weeks, there were multiple people that broke that 4-minute mile. And it's really interesting to see how powerful the human mind is. And now you've got this generation of athletes that have gone their entire lives with people telling them that they can't do something because it's impossible. And then you start to see people like Alan Gelfand, where, historically skateboarding was doing 360s and riding really smooth on walls. And all of a sudden he figured out that he could actually jump on his board. Alan was, he was a kid at the time, and he was skating with these two other guys. One of them was Pat No, and the other one was Mike McGill. And I was fortunate enough several years ago to be sitting in a med room covering a skate event for Vans while the three of them were, were in there. And there was another legend in the industry, which was Tony Magnuson. And Tony was asking Mike and Pat how they invented the ollie, and to be there firsthand and hear history from them was just it was an awesome moment for me. But they kept just kind of equating it to saying is like, well, people just said we couldn't do it and we wanted to prove them wrong. And that was kind of like the whole mindset behind everything that happens in the action sports industry. And when you go a couple of years after the ollie was invented, that's when you start to see skateboarding really take off. And in the early 80s, Rodney Mullen was the one who actually landed the first kickflip out of it. And once we figured out that we could, one, jump on a skateboard, and two, we could flip the board, everything changed. There's a great documentary on, I think it was HBO, called Until the Wheels Fall Off, and it's following Tony Hawk. Tony Hawk won his first competition in 1982. Flip Tricks had just come out in 1983, and there's this really good interview with a legendary skater by the name of Dwayne Peters, where they're asking him about how he felt with Tony coming into competition. Because before, it was like all you could do was just get above the coping, do a 360, 720, any type of spinning on the board and land back in the ramp. But then Tony comes out and he starts doing all these flip tricks, and you can really see this angst in Dwayne's face, because it's a generational gap at that point. And from the mid 80s, it just accelerated like crazy. The fun part about it is once you hit the mid 80s, these sports were so popular because they were glamorized in Hollywood in the TV series Gidget in the 60s. And then Surfer Magazine had come out. Transworld Skateboarding now had a magazine. And then again, the photos that you're looking at now, this is Huntington Beach, 1986. This is what has developed into what we call the US Open of surf. But back in the 80s, this was called the OP Pro. This was the largest spectator event in all of California. The athletes were, doing their thing, and all of a sudden riots broke out. And this kind of gave the action sports world, or surf skate, kind of a bad reputation for it, saying that, the kids that gravitate towards these types of sports are kind of that lost generation, which was kind of the basis for Generation X. And again, it's that latchkey generation that were told their entire lives that they can't do something, and their entire response was, watch me. Which is when you ask like how people like me get into these sort of things, it's because we grew up right in the heart of it. In the mid 90s, I was in high school, and every single photo you're looking at was me. I used to skate heavily. Snowboarding had just come out. We were borrowing people's snowmobiles just so we could go up ski runs, because not every ski lift would allow snowboards on it, and a lot of times we had to do backcountry stuff. And surf skate was kind of developing at the same time. The photo in the bottom that's me with my girlfriend, who's now my wife. She kind of fell into it with me as well. She was more of a snowboarder at the time, but it was really like her parents just hated the idea of having a surfer or skateboarder anywhere near their daughter. But now it's a completely different world, because we're seeing by 1995, X Games had become an actual event. And then it was 1998 when snowboarding became an Olympic event. And people don't realize that snowboarding wasn't trying to get into the Olympics so much as the Olympics were losing their ratings and backing, and they were trying to get a hold of the younger generation so they could get more viewers in. And they approached snowboarding, and that's where that sort of came from. And it's really interesting to see it now, because we've got surf and skate and BMX in the Olympics. So we've come from a brand new sport that wasn't even on anybody's radar to being a major force in the social media aspect and what athletes are doing. And it's now becoming just kind of common for a lot of people to really gravitate towards these types of sports. So just to give you an idea of how popular these things are, when you look at 2023, the X Games Ventura stuff, we had 50,000 plus attendees who just coming to watch. And then on TV, it averaged 460,000 people every single day across that weekend where it was aired on TV. And if you're interested in getting involved, I encourage you, X Games will be held in Sacramento this year, which is going to run from August 22nd through the 24th. If you're in town, come out and watch it. It's really different than any other sporting event out there. So with that said, let's take a quick look at the kinematic sequence and why kinematics and biomechanics are so important with it. Because if you do anything out of order, the system fails. And like this picture is showing you, is like, if you're trying to stand up on a surfboard before you hit the water, you fail. Like, that's not surfing, right? It's the same thing in any sport. The sequence of events have to happen in such a way, and if they don't, if one part of the body does something out of order, whatever you're doing is going to fail and lead to injury. So this graph on the left of your screen up here What this is actually looking at is the ollie up average ground force. And it's the ground force here, and then it's the percent contact time of like how much you're in contact with the board. And you see that the spike comes up, but this is multiple different skaters that they're graphing here, and everybody that's doing an ollie basically follows a similar curve on it. But when you get into the medial lateral movement, which is your front foot sliding forward, it's all over the place. And this corresponds to how high you're going to get, how far you're going to ollie, or how much force is being applied to move that board forward, as opposed to just slapping the tail on the ground. The graph over here, the reason I put this in here, this is actually from golf, to really drive home biomechanics and a sequence of events with the kinetic chain, is when you're trying to swing a club, while you're bringing the club back, your pelvis is what's actually driving motion. And then when you actually initiate at the top of the backswing, the pelvis goes forward, and then you're seeing the upper body, and then the blue line is your arm, and then the club, and they start to decelerate in basically that same order, right? If you push the pelvis above the thorax and the thorax initiates motion first, you're going to lose a lot of that kinetic energy, and the energy from the pelvis is going to dissipate somewhere in the body. And that's where you start to see those athletes that have really interesting injuries where all their imaging studies don't show pathology, but yet they still hurt. So if you're not paying attention to the biomechanics, you're going to miss out on a lot of these types of injuries. So on this bottom segment here, it's just kind of showing you what's happening on these graphs, showing that you have to load up the lower body, put your weight more on the back foot. The back foot has to drop down, slap the tail. At the same time, the front leg has to lift, and then you have to lift the back foot at the same time that front foot has to slide forward across the board. If any of these things happen out of order, you're not going to clear whatever obstacle or do whatever trick you're going to do. And instead, because of the nature of what you do, you're going to have an inversion injury, because that is the predominant motion that you do. It doesn't necessarily mean that you're going to mess up your ankle. A lot of times it just leads to a fall, which is where we get into the numbers of it when you're looking at what's actually happening when somebody falls skateboarding. The overwhelming majority of the time is you're going to see a fracture, which translates into a foosh injury, fall on outstretched hand, where you're trying to brace yourself. And so you see more wrist injuries than you do ankle injuries in skateboarding. But in terms of sprains and strains, the ankle overwhelmingly outweighs the wrist and on that front. This x-ray that you're seeing over here is trimalleolar fracture with the dislocation. This is actually my ankle. It was a forced eversion with a lateral rotation on it. And, ankles explode when you put that much force on it. Treatment of these types of injuries, depending on the type nature of the fracture, scaphoid injuries being the most common in the wrist, a lot of it is just bracing. That thumb spica is huge. Unfortunately, in the action sports world, the athletes don't like to tell you when they're hurt. It's that simple mentality that athletes have where they think you're going to pull them from competition. And I tell all my fellows, our goal as a sports med provider is not to pull people from competition. It's to figure out what their goal is and get them to that goal as safely as possible. So when you have to have a good understanding of what they're trying to do in terms of the sport, so you could figure out the correct brace and what their risk stratification is before you can send them back out. But in skateboarding, overwhelmingly, you're looking at fractures. It's a much higher trauma sport than surfing. But you do see a lot of similar type of injuries just by nature of it. It's just instead of falling in water, you're falling on concrete most of the time. One of the most underreported injuries that we see in skateboarding is the contusions and the basic scrapes. This guy on the right is one of our X Games athletes. And these guys fall all the time in training, and they come in to talk to us just because they want to get cleaned up so they can get back to competition. But when you're examining any sort of athlete, you got to make sure you're doing a full eval on them, making sure every joint moves, take off their pads, and get a good look at it. We've had numerous times where an athlete had fallen, and we were focusing on the obvious injury, but then when we pulled the pads off, you realize there's a giant laceration underneath the pad just from the trauma, and had we not taken the pads off, we wouldn't have known. This ankle on the left, this is the post-surgical fix. This is, again, my ankle, but it's just showing the treatment for these types of ankle injuries. They can be pretty intense and make it very difficult for athletes to get back to sport. And so when we switch gears and look at surfing for a minute, the overwhelming most common injury that we see in surfing is lacerations. Lacerations far outweigh everything. The skin type injuries, and then the next time is just a bruise. Every once in a while, you'll see some bone injuries, but that depends on the nature of the impact that they're seeing. The foot that you're seeing here, this was a stingray injury, which was a puncture wound right here, but you can see the destruction of the underlying soft tissue around it there. This is also my foot, by the way. Stingrays, in terms of surf, I can't tell you how many times I've been on the beach and seen tourists out there step on a stingray, and then I'm trying to get over there so I could help them. And there's this misconception that you can treat the pain from a stingray injury by peeing on it. I've had numerous conversations with people. Unfortunately, I usually get there a little too late, and they've already had one or two of their friends pee on it, and then they're still writhing in pain. And I get to be the one to tell them that that doesn't work. The urine has a high concentration of ammonia, and that can neutralize some of the acid found in jellyfish, but it does nothing for stingrays. The way you would treat a stingray injury is hot water. Soak it. Just submerge the foot in hot water and let it sit there for 20-30 minutes, and then test it out. The hot water, it denatures some of the proteins that were coated on the stingray's little barb, and it immediately eliminates the pain. So in terms of the most common injury, it's either going to be a laceration or it's going to be a stingray, something along those, some type of exposure thing. Surfing, you can actually break down, and these are put in order, where the lacerations are going to be the most common, starting with the face and the feet, because of the two obvious things. One's you're walking on a reef, so you're going to cut your feet. And the face comes into it because you get hit by the board quite a bit. Contusions, same thing. You got to watch out for the board. Strains and sprains are usually more of an overuse injury. You don't see a lot of them. In the older generation, you will see a lot more of a kind of like a rotator cuff pathology just from the constant paddling of it, but you don't see a lot of strains and sprains from surfing. Fractures, occasionally you do, but again, it's the nature of being hit by something, whether it's the rock under the water or the board coming back and hitting you in the face and seeing facial fractures. Chest fractures, what it's referring to is rib fractures. And a lot of times if you get pulled up into the wave and come over the falls, you can land on your board or you can get pushed into the reef, and all bets are off on what's going to hit first. So when we get into some of these cases that we deal with, it's really difficult on our side. If you're covering a football game and somebody goes down, you know exactly how to spine board them and get them off the field. When you're covering a surf event or a skate event, it's drastically different. Every obstacle is going to be different. So we have to take care and practice these things until we get it just right. So we actually will put one of our medical team on the ground, we'll practice spine boarding them and figure out how to get them in and out of pools, off ramps, in and out of the water. It's a really big deal whenever you're covering an event like this to know, how do I get somebody out and back into a safe environment so I can actually work and assess them. This skateboarder on the left, this is Kirra Reynolds. He's a professional surfer and a professional skateboarder. And this is Dr. Andrew Noby from UC Irvine. He's one of my prior fellows. And what he's using is a butterfly to examine Himana's thumb. Himana is one of my favorite skaters because he goes so fast and so big. But anytime you increase speed, and have that inertia, when you fall or twist or over rotate, it can translate into something tearing, breaking, or just coming apart. Himana, I don't know if my video will play. Let's try it. Himana, we've spine boarded him numerous times at various events. The event that you're looking at right now is the Vans Pool Party, which if you're bored, you can catch this online because it's going to be going live on the 18th, this Saturday. I'll be at the event. This is Kirra Reynolds right here skating. And if you watch closely on this next right here, he's sliding across it, over rotates and slams at the bottom of the bowl, leading to the obvious concussion and head injury. But we had to spine board him, get him out, get him to the hospital, and he came out okay. But this is not uncommon in skateboarding to see these types of injuries when boards slide off of the coping on a pool or off of a handrail. So you've got to be quick to react on these types of things. All right, so the next interesting case, if you don't know who this is Jagger Eaton. He was the first Team USA skateboarders to win. He got bronze medal in the 2020 Olympics, and then he went back in the most recent Olympics and got a silver medal in skateboarding. He had a really bad ankle injury leading into the 2020 Olympics. He went on Jimmy Kimmel and was talking about how he had a broken ankle and was skating on it. He had a inversion injury in training, which led to a high ankle sprain and a posterior malfracture. The fracture was minimally displaced at the time. And we were able to effectively rehab him, but there was a scary moment where we were talking with the surgeon because of that high ankle sprain leading to a syndesmotic disruption of, do we need to send him to surgery, or can we just conservatively manage and then hopefully get him to the first ever Olympics? He ended up choosing the conservative route and did exceptionally well at the Olympics. But when you watch his post-Olympic interview and hear his story, he kind of downplays the difficulty of what he was dealing with. And he's a really good friend of mine, and he loves the fact that I talk about his story all the time because it's very inspiring to me. But it's watching these guys skate on stuff like this, or when they surf on stuff like this, it's really inspiring to see like how much can the human body endure. And it goes back to that Roger Bannister mentality of like, they do it because people told them that they can't. This is one of skateboarding's anomalies. If you recognize, this is Christian Hosoi. He's from the same era as Dwayne Peters and Tony Hawk. Christian would have had the same popularity as Tony Hawk, except he got in trouble with the law and ended up doing a little bit of jail time. But the reason he is an anomaly is he is one of the few skateboarders that have made it to the legend status that has never had a serious injury. He's never really broken a bone, never really had surgery, never really been hospitalized for anything. And that blows my mind. Really nice guy and really enthusiastic about skateboarding now, but it just, in terms of skateboarding, to go your entire life without having a major injury, it's just unheard of. So he will always be a special case in my book. And to give you an idea about the exposure type of stuff in surfing, this photo in the upper left, this is an old roommate of mine. The injuries occur because sometimes when you're surfing point breaks, you want to get out into the lineup faster. So instead of paddling out and around the wave, you'll scale a cliff, go down the point, jump off a rock, but you got to time it just right. But if you mistime that wave when you jump, that wave's going to push you right back into the rocks. And I can't tell you how many times I've seen it happen. I used to live in Santa Cruz, and I'd watch guys jump off the point at Steamer Lane and just get annihilated on the rocks, only to be drug out of the water by a lifeguard. So these can be really bad injuries depending on the size of the wave. Those of you that are on the coast, or if you're up in Hawaii or you've probably seen this happen once or twice, and it can be pretty bad. The other thing to note is this is a low tide shot at a break in the Caribbean. You got to know what you're going over the top of, because when you fall, you're going to go into the water, and if you don't know how shallow or deep it is, you're going to be hitting this stuff. And whether there's sea urchins on it, or fire coral, or just hitting a reef, these can lead to really bad broken bones, lacerations, and really deep cuts that can have really bad infections on them. So you really got to be ready for that. And then the other thing that gets downplayed, again, both of these photos are me. Those very old photos, but I was surfing in Florida, and its sun exposure gets often underreported. You can see the difference in coloration, and I grew up surfing and growing up on the beach, and I'm still guilty of not wearing sunscreen. But the sun exposure can be really bad to the point where people will blister with it, and you can be in pretty rough shape. This photo on the right here, I was on a surf trip in the Caribbean, and I fell on a wave, and I was pulling my leash to get the board back to me, and the board hit me in the face. I ended up breaking a tooth. Rather than going home, I had this epoxy ding repair kit, which was called Dingdo, and we basically made a cap for my tooth out of it, so I didn't have to fly home. And the minute I got home, I went to the dentist, and I took the Dingdo with me just to show him. And he looked at the ingredients, and then he pulled out the epoxy that they used to make a cap for a tooth, and they were the same ingredients. And then he proceeded to tell me what a great job I did on making a cap for it, but it saved our whole surf trip. So surfing, you got to be a little bit more creative sometimes. I'm not condoning that anybody make a tooth repair out of a ding repair kit. Probably not the healthiest thing I've done in my life, but and another, just a final point on the gravity of what's happening with action sports is when you look at some of these ramps, what you're looking at is the mega ramp, and it's a 9-story takeoff on this side with a huge gap in the middle and a gigantic quarter pipe on the other end of it. And if just the mental component of staring down this ramp at 9 stories high, and then knowing that you're going to go over this thing. And again, all this stuff comes because people didn't think it was possible. And now here we are doing it. And you look back at even things like motocross, like nobody ever thought you could backflip a motorcycle. And yet you got guys like Harry Bink doing front flips on them now. So the industry just, keeps progressing itself forward by finding, new and bigger and better tricks to do. you know, if you're interested in these types of sports, I encourage you to reach out to us out in Long Beach Memorial. You know, all of our fellows get involved in a lot of these types of sports, and we love being involved in alternative sports. We're always looking for the alternative sports, because in terms of when you look at family medicine, we always talk about the underserved population. And I can't think of a more underserved population than these alternative sports, like the ones that we're covering today. You know, I love covering the normal stuff like football, baseball, basketball, but you know, there's these athletes out there that are just getting beat up and they don't really have a lot of medical behind them. And skateboarding and surfing in particular, there's not a lot of research that's been done. So I implore you as medical students and residents, if, you know, do some research. And if you're interested in it, reach out. I'm more than happy to point you in the right direction and help you find some contacts for it. So you guys can start being the next generation to really make this thing more of an evidence-based medicine side. So, but that's it. Thanks for listening.
Thank you, Dr. Snodgrass. I'm actually recovering currently from I don't know if you guys can see, it's better, but I'm recovering from a jellyfish sting from surfing. So yeah, definitely those exposure injuries. So now I will introduce Major Brian Merrigan, who will present on scuba. So Major Brian Merrigan grew up just south of Boston, graduated with a Bachelor's of Arts in Economics from Amherst College in 2011, where he played football and baseball. He graduated from medical school at the Uniformed Service University of Health Sciences in 2017 and completed his residency in family medicine at Fort Belvoir Community Hospital in 2020. Upon graduating residency, Dr. Merrigan served as a physician for an Army Special Operations Unit from 2020 to 2023, deploying twice in support of Operation Inherent Resolve. In 2021, he attended and graduated from the United States Navy Dive Medical Officer course, and then served as the Chief Dive Medical Officer for his unit. He graduated from Sports Medicine Fellowship in 2024 and currently serves as one of the core faculty at the National Capital Consortium Sports Medicine Fellowship at Fort Belvoir, Virginia. Major Merrigan, the floor is yours.
All right, thanks so much, Kirra. I'm going to go ahead and share my screen here. All right. Awesome. Well, thank you very much. Yeah, I'm Brian Merrigan, and I'm going to be talking about scuba today. Scuba stands for self-contained underwater breathing apparatus. And advance here. Here we go. Any military lecture, we got to give disclosures. I have none today, no financial disclosures. The opinions in this lecture are going to be my own. All right, educational objective. So I'll talk a little bit about me, how I got involved in dive medicine. We don't have as much biomechanics with diving, but we do have a lot of physics. So we'll take you back to college a little bit and go over some physics and how those impact the human body. And then lastly, we're going to go over the most common dive injury and talk about how to evaluate and treat it. All right, so like Kirra said, I went to the military med school, which is in Bethesda, Maryland, commissioned into the Army. The best thing I got out of med school was my wife. She's also an Army physician who's here at Fort Belvoir. Did family med training, and then spent some time in an operational community for 3 years. Had a lot of fun, came back, did sports med fellowship, and now I was fortunate enough to stay on as core faculty here at the Military Sports Medicine Fellowship, which is the largest sports medicine fellowship in the country. We have 8 active duty fellows currently, a mix of Army, Navy, and Air Force. I've got to do some cool things in my time in the military. I'm airborne qualified, which just means I can jump out of airplanes. I'm a flight surgeon, which means I can take care of pilots. Does not mean I do surgery on airplanes. And then lastly, I'm a dive medical officer. And what that is, it's a physician in the military who, 1, can dive, and 2, is trained to take care of other divers. So most people get into scuba diving because they get to do things like this, dive in beautiful turquoise water, looking at marine life. Unfortunately, that was not my introduction into scuba diving. This was me at dive school on our 2nd week, doing some underwater confidence training, as they call it. They make you wear these wonderful short brown shorts that you see here. That's my instructor in the orange gloves, and he had basically just roughed me up, took off my mask, pulled out my regulator, turned off the air. And we go through a series of these hits that progress. And the idea is, 1, it teaches you to become comfortable in the water, teaches you to understand what your patients or your divers are going to be going through in some of the missions that they may be on. And it really gives you a good perspective. It's not all that fun, but looking back on it, you know, it is something to look back on fondly. So like I said, this is how I got into diving. I was in the military, we call it voluntold. I was in a unit that had dive teams and we needed a dive medical officer. So I was told that I was going to be going to the Navy dive medical officer course. As an Army guy, I never saw that in my future, but made the best of it. And it was a tremendous course. It's 9 weeks. It's at the Naval Dive and Salvage Training Center in Panama City Beach, which is where all the Navy, Air Force, and the Army engineer divers train. And the first 7 weeks really are diving. And you can see this picture on the left is of me doing some hard hat diving. The picture on the right, this is the rig that most special operation divers, including the divers in my unit, would use. This is a Mark 25, which is a rebreather, which is a pretty cool rig because it's got a CO2 scrubber and there's no bubbles that it emits. And so the reason for that is that, you know, if they're doing a mission and they need to be stealth under the water, there's going to be no surface bubbles that they can be detected. All right, so touch on a little bit of epidemiology. Scuba diving is a very popular sport. You can see 2 to 3.5 million scuba divers in the United States and up to 9 million scuba divers worldwide. Average age is about 30. Good mix, males and females. And this is a market that, and a sport that really is just continuing to grow. And as you can imagine, the most popular states where we see scuba diving in the United States are going to be states by the coast. Talking a little bit about dive physics, Boyle's law, for those of you who remember back in your physics class, this is really pertinent when we talk about dive medicine. And Boyle's law states that pressure and volume are inversely related. Okay, so what that means from a dive perspective is that as someone is descending in the water column, that pressure is going to be increasing, and simultaneously the volume of air in an enclosed space, be it your lungs, your middle ear, is going to be pressure is going to be increasing and the volume is going to be decreasing. The reverse is true. If you're ascending in the water column, that pressure is going to be decreasing and the volume is going to be expanding. Okay, and this is really what causes barotrauma, which is going to be our most common dive injury that we're going to see. And barotrauma is when a diver is unable to equalize those pressure and volume changes, and they subsequently have damage to mechanical tissues and really can be any part of the body. Okay, the picture on the right here, these are some of the training that our divers would go through. This is part of their drown proof training. You can see their hands and their legs are bound and they're basically doing bobs up and down. They have to do that for 5 minutes and then it progresses and it actually gets worse from there. But again, as they're descending in the water, pressure is going to be increasing, volume is going to be decreasing, and then vice versa as they're ascending. Okay, this is a chart that kind of further explains that. So as we're sitting here at sea level, we're at 1 atmosphere of pressure. Okay, and the relative volume that we're breathing in our lungs, the relative volume in our middle ear is going to be 1. And you can see for every 33 feet that you descend in the water as you're diving, that atmospheric pressure is going to increase by 1, and then you're going to have a relative volume change. And the key takeaway from this chart is the most drastic volume change that we see is actually in that first 33 feet of seawater, where we have a 50% drop in volume. Okay. And for this reason, you can actually start to see barotrauma in very shallow water. Okay. And we'll talk a little bit more about that in a bit. So barotrauma really can affect any enclosed airspace in the body. The most common is going to be the middle ear, followed by the sinuses. And most commonly, barotrauma happens on descent as that pressure is increasing. Okay, it can happen on ascent. And when we see it on ascent, it's actually more commonly that we see barotrauma of the lungs. And this usually happens for one of 2 reasons. The first is someone bolts to the surface. And that's part of the reason we do confidence training, is to teach you not to bolt if something goes wrong. Because if you bolt, you're going to have a rapid expansion of the volume of gas in your lungs, particularly when you're breathing compressed air, as that pressure is decreasing. The second way it can happen is if someone holds their breath as they're ascending, right? So you never hold your breath while you're diving. But what happens is you get rapid expansion of the air in your lungs, and you can get rupture of the alveolar walls. This is the diagram in the bottom right. And then that air can get into the mediastinum, the subcutaneous tissues, you can get emphysema, can cause a pneumothorax. And then arguably the most devastating dive injury is something called an arterial gas embolism. And that's when the air gets into the pulmonary vasculature and then embolizes to the brain. And really, it's a stroke-like picture. And that's something that needs to be treated urgently in a recompression chamber. Okay, but as I said, middle ear barotrauma, this by far is going to be the most common dive injury. As you can see, 80% of recreational and professional divers will experience this at some point in their lifetime, and very common with inexperienced divers. So 30% of first-time divers will experience middle ear barotrauma. If you look at the diagram in the bottom right there, why does this happen? Again, as you're descending, the pressure is going to be increasing and pushing up on that tympanic membrane, while simultaneously that air in the middle ear, the volume of gas is going to be decreasing. So you get this almost vacuum effect. And as a result, if you're unable to equalize, and the way you equalize is by pushing air up through your eustachian tube. And there's a couple ways to do that. The most common is going to be a Valsalva maneuver, where you, as you all know, you grab your nose and clear your ears. Some more experienced divers can actually just do it by moving their jaw or yawning. But the whole idea is you need to kind of provide a counter force against that tympanic membrane as you're descending, okay? And so with first-time divers, they're often inexperienced. Maybe they don't know how to do a Valsalva, and so sometimes that's why we'll see it. And then more commonly, the reason we'll see this is someone's just congested. They have upper respiratory infection, eustachian tube dysfunction, and they try to dive anyways, and it'll result in barotrauma. Okay, so how does this present? This really presents with pain and pressure in the ears as someone's descending. And as I talked about, due to those rapid pressure changes and volume changes in the first 33 feet, we can actually start to see barotrauma in water as shallow as 4 feet. And if that pressure is not equalized, you can get a tympanic membrane rupture in water as shallow as 10 feet. You know, you think about if you're just jumping into a pool, if you're going down to a 10-foot pool, oftentimes you have to clear your ear. And that's the reason why you're preventing barotrauma, okay? So if someone continues to try to descend, that pain's gonna progress. And then eventually you will get a tympanic membrane rupture, which actually temporarily causes some pain relief. But then as that water rushes into the middle ear, often it results in vertigo, tinnitus, etc. Okay, the key with this is prevention, prevention, prevention. So the bottom line is you should never let your divers dive if they've got an upper respiratory infection, they're congested, they have an ear infection, or if they're unable to equalize. You know, one of the things we have to do before we get in the water every time at dive school is your dive supervisor makes you clear. All right, so everyone has to go and do a Valsalva and give the A-OK that you're good to go. If you can't clear that day, you're not diving, okay? Decongestions can help. So, you know, if someone is just mildly congested, treating them with Afrin, Sudafed in order to help them clear is not wrong, okay? During the dive itself, the key is you really want to equalize regularly. And you're doing this every 4 to 5 feet as you're descending in the water, okay, to prevent barotrauma. If you're having issues, you have to ascend until you can clear. And if you can't clear, then you really need to cease that dive, because if you continue to try to dive or push it, you're going to run into issues. Evaluation, history is key, right? Ask your diver what they were experiencing. Most of the time, they're just going to say pain. If they're telling you they had any other symptoms, vestibular symptoms, tinnitus, that should make you a little bit more concerned. But if it's just pain, you want to do a good otoscopic exam. This is the modified TEED scoring. That's one of the scoring systems out there that we look at. And you can see it really progresses from a normal appearing tympanic membrane to the bottom right being where you've got a tympanic membrane rupture. And then the other 4 are kind of varying degrees of hemorrhage, you know, mild hemorrhage to D&E where you've got gross hemorrhage, okay? Management for these, you know, decongestants, again, Sudafed, Afrin, if they're in pain, NSAIDs. Obviously, if on your exam you identify an infection, you're going to want to treat them with antibiotics. If they did have a TM perf while they were diving, the recommendation is to do prophylactic ciprofloxacin drops, BID for 3 to 5 days. The one key is you want to avoid aminoglycosides, particularly if they have a perf, because that can be ototoxic, okay? And then when can they return to dive? They really have to be asymptomatic they have to have a normal exam, and they have to be able to equalize. And this is very variable. You know, someone who's got had some mild pain, but they have a normal exam, you may be able to treat them with Afrin, give them some Sudafed. They may be back in the water the next day. Okay. Other people who on exam, you know, more you're seeing some of that that hemorrhage. That's probably going to take a little bit longer, more in the ballpark of weeks. Okay. If they have a perf, this typically is going to take 1 to 3 months. Usually heals on its own. Benign neglect is really the treatment. Give it about 4 weeks. If it's not healed by a month, that's someone, you know, a month or two, I'd probably send to ENT. And then certainly, again, if your diver has any vestibular symptoms or their hearing loss, tinnitus, any of those are kind of more red flag symptoms that you'd want ENT to take a look at. Okay. But again, certainly they're not getting back in the water until that TM is completely healed and they can clear and have a normal exam. All right. These are my resources, and that's all I have. Thank you so much.
Thank you, Major Merrigan. So before moving to Q&A, if anyone has any, I just want to thank everyone for presenting today. Yeah, so just thank you for, you know, sharing part of your expertise with our resident and student members tonight. So now, yeah, if there's any questions, feel free to put them in the chat. So before we conclude tonight's webinar, I just want to encourage you to join us for 2 more MSIG webinars this week. There's another one. Oh, sorry, we do have a question. Okay, so this is for surfing. So if there is a cervical spine injury during surfing, how do you get to the patient?
Yeah, cervical spine injuries in the water pose a very unique difficulty because you really want to do your best to not move them. If you've got lifeguards nearby, they are specially trained for this type of thing, especially if you're in a high surf environment. Otherwise, your goal is just to stabilize them on their board, on your board, and just get them to the beach as quickly as possible. There's really no magic to it because you're trying to prevent them from drowning first and foremost. And then, you know, once you get them to the beach, you can, you know, immobilize C-spine a little easier. If you have someone there to help you, one of the ways that we were trained to do it in the water is you can kind of put them face down in the water, put the board on top of them, and then reach over the top and then roll them back over. But it's a lot harder to do than you think. So it's best left to the professionals in terms of if there's lifeguards available, get the lifeguard to do it because that's what they've been trained to do. But yeah, the C-spine injuries in the water are really tough. That's a good question.
Thank you, Dr. Snodgrass. Yeah, so like I was saying before we conclude tonight, I just want to encourage everyone to attend 2 more MSIG webinars this week. Tomorrow, Tuesday, January 14th at 8:30 Eastern Time. The series will continue on textbook injuries featuring 4 presentations. Dr. Robert Bowers will make a presentation on baseball. Dr. Aaron Lear will present on softball. Dr. David Olson on football, and Dr. Ashley Austin on basketball. And then on Wednesday, January 16th, again, 8:30 Eastern Time, the MSIG webinar textbook injuries will have another presentation with Dr. Joanne Allen on sailing, Dr. Christine Carlson on rowing, Dr. Kelly Ryan on equestrian sports, and Dr. James Eggert on rodeo. So if there's no final questions, it was my pleasure to serve as the moderator tonight. Thank you everyone for attending tonight's MSIG webinar, and that is all. So have a good night, everyone. Thank you again to our presenters.